And welcome to lesson 2, where we will focus on tic disorders. And the verse guiding this lesson is from Psalm 145, verse 18. The Lord is near to all who call out to him, all who call out to him with integrity. A tic disorder is one that involves the involuntary motor movements or vocalizations, and there are several criteria to these motor movements or vocalizations. Certainly, they are involuntary, but also often sudden, rapid, recurrent, or repetitive. They're non rhythmic, they're short bursts or may occur in a series. They may involve various muscle groups. They may be simple or complex, and they may be transient or chronic. And here we see a crosswalk between the ICD-10 and the DSM-4, where we have the diagnoses of transient tic disorder, chronic motor or vocal tic disorder, and then we have in the DSM, we have Tourette's disorder. ICD-10, the nomenclature is combined vocal and multiple motor tic disorder. And then we have those other or unspecified tic disorders. And we can have a wide range of motor tics. Some are very simple and sudden. One of the most common motor tics that I've seen is eye blinking. Facial grimacing is common as well. Some tics can be very complex behavioral patterns. I have one patient who would bend over backwards as if doing a back bend. Some can involve things like crouching or hopping. Copropraxia would be the involuntary motor tic that includes something profane such as giving the finger. Echopraxia would be mirroring another's behavior. Some motor tics can include self-harm behaviors such as slapping, punching, or pinching. And we have vocal or phonic tics, which are involuntary utterances. One of the most common vocal tics that I have seen is that of throat clearing. Vocal tics can consist of sounds, noises, sentences, or words, and they can be simple or complex as well. Whenever you hear the term Tourette syndrome, I think people often think of coprolalia, which is the involuntary utterance of profanity. Echolalia would be the involuntary utterance of repeating another's words. And then palalia, the involuntary repetition of one's own words. So copropraxia and coprolalia are pretty uncommon occurrences with Tourette's or tic disorders. Here is a list of some of the most common tics. So motor tics, we have eye blinking, rolling of eyes, grimacing, shaking of head, twitching shoulders, twitching of the torso and pelvis or abdomen, and then moving hands or arms or feet or legs. And some common vocal tics include coughing, throat clearing, sniffing, whistling, grunting, animal sounds, uttering of syllables, uttering of words, or shouting. And here we see the differentiation of Tourette's syndrome from transient tic disorders with the diagnostic criteria. For transient tic disorder, the symptoms are occurring less than 12 months. The individual mostly is school age, and there's usually no specific treatment for it unless it's very impairing or upsetting or disturbing to the child. And again, an individual with a tic disorder usually will start with a provisional diagnosis of transient tic disorder that certainly could progress to the diagnosis of a Tourette syndrome if they meet this criteria. It has to occur almost every day for over a year. And the onset here, it's usually under 18. Tourette syndrome needs to include several motor tics and at least one vocal tic. Transient tic disorders are fairly common in school-age children, and the epidemiology often identifies a prevalence of 4 to 12% of all children. Tourette's syndrome is a little bit less commonly occurring, and the prevalence is estimated to be about 1%. It is more frequently occurring in boys rather than girls, 3 to 4 times the rate, and much more common to occur in children and adolescents over adults. There is a familial predisposition as well. The onset and course. The onset is usually between the ages of 2 to 15 years, and the peak is at about 6 to 8 years of age. Motor tics usually occur in the face first, and then later can involve shoulders, torso, or extremities. Vocal tics usually do not emerge until 2 to 4 years after the occurrence of motor tics. Fluctuations are very common. Tics are noted to wax and wane, and these fluctuations can occur every 6 to 12 weeks with variations in location, complexity, the type of tics, as well as intensity or frequency. Often, if a child persists, they will see improvement. However, if the tic becomes impairing, if they're the subject of bullying and teasing at school and they're very embarrassed, then then treatment is needed. Otherwise, transient tic disorder, just like its name, is transient and often can remit spontaneously. And so here we see an image of fluctuations in course with waxing and waning of the tic severity as well as the duration. Older children can be seen to have better control of their tics and may be able to even suppress them at times for minutes up to hours. Sometimes, though, this does result in an increased intensity or frequency after the school day is over. And it is often noted to have a worsening of symptoms during adolescence. Frequently, we see remission during young adulthood. A poorer prognosis for tic disorders is seen with individuals who have a strong familial history of tic disorders and when there is the existence of vocal tics or complex tics. Individuals who have comorbid attention deficit hyperactivity disorder or obsessive compulsive disorder can also have a poor prognosis. Spontaneous remission is seen in 50 to 70% of individuals with chronic simple or multiple tics. Spontaneous remission also occurs in, studies have shown anywhere from 3 up to 40% of individuals with Tourette syndrome. In your assessment of tics, you want to identify the ameliorating and aggravating factors. And so some things that can decrease tics includes distraction, high concentration tasks. Cannabis or alcohol use are noted to decrease tics, and intentional movements. Some things that can increase tics include strong emotions such as stress, fear, joy, as well as the experience of emotional trauma, social pressure, or tension. The cause of tic disorders is multifactorial, so we certainly have some genetic influences, as well as neurobiological, psychological, and environmental. It's thought to be a dysregulation in the corticostriato-thalamocortical circuits. Deviations in the dopaminergic and serotonergic systems have also been identified, and there is often an increased dopamine activity seen in the basal ganglia or deficient subcortical inhibition. As well, impaired autonomic control of movement can be a factor. And some risk factors for tic disorders include possible pre, peri, and postnatal risk factors such as premature birth, hypoxia, low birth weight, nicotine and caffeine use during pregnancy. As well, there can be some rare secondary causes such as tumors, poisonings, infection, or head trauma. 50% of tic disorders are noted to be heritable. So the family predisposition is a strong risk factor. Some changes can be seen on medical imaging, such as a possible decreased brain volume, especially in the basal ganglia or the corpus callosum. There also can be noted to see a deviation of glucose metabolism in the basal ganglia, prefrontal cortex, somatic sensory motor cortex, insula, or the temporal lobe. For the assessment of a child or adolescent with a tic disorder, you really need a detailed medical history. And as well, in the psychiatric evaluation, some standardized questionnaires can be helpful, such as the Child Behavior Checklist or the Strengths and Difficulties Questionnaire. Interviews with the child and the family can include rating scales such as the Yale Global Tic Severity Scale or the Tourette Syndrome Severity Scale. Parental self-rating scales are available as well, with the Yale Tourette Syndrome and Symptom List revised. Of course, assessment needs to include a physical examination with a very detailed neurological exam and an EEG. There are some differential diagnoses to consider when a child or adolescent is presenting with tics, and they often can vary according to the aspect of the tic. So, for example, a child with a tic repetition should be evaluated for an obsessive compulsive phenomena. Preoccupation with tic control, evaluating for ADHD. An exaggerated tic may have a psychogenic origin. Eye rolling could be indicative of absence or partial seizures. Rapid shuffling steps could be akathisia or a juvenile Parkinsonism or compulsion. Jerky tics could be chorea disorder, shuddering tics, a myoclonus, and tics during sleep could be indicative of a restless leg syndrome or other parasomnia. There are some very common comorbidities for tic disorders. So, some psychiatric conditions that are often associated with tic disorders include a comorbid attention deficit hyperactivity disorder. It is estimated that anywhere from 40 to 60% of children with a tic disorder also have ADHD. This can be difficult because the medications to treat ADHD actually often worsen tics. So, psychostimulants and even the SNRI atomoxetine will often worsen tics. And so, things such as guanfacine may need to be used or clonidine. Obsessive compulsive symptoms are seen in 40 to 70% of children with tic disorders. Anxiety disorder is very common, 25 to 40%. And depressive symptoms are noted in around 50%. And certainly that can also be related to some of the psychosocial impacts of tics with experience with their peers at school. Sleeping disorders are also common. Anywhere from 12 to 44% have been um, evidenced. Treatment for tic disorders includes, of course, psychoeducation for the child, the teen, and families. They are often quite upset and concerned, and self help and support groups can be beneficial. And these are often available virtually today as well. Cognitive behavioral therapies can help, and we have several different protocols, such as habit reversal training, exposure response prevention, and of course, relaxation training and contingency management. Family therapy is helpful as well. Sometimes there can develop some very negative family dynamics. Many parents often think that the child is that these behaviors are voluntary, and so really helping the parent to understand the involuntary nature is crucial. We don't really have good medication for the treatment of tic disorders. There are several medications that are used off label, such as Haldol, Orap, and Clonidine. And we only use medication when the tic disorder intensity and frequency is such that it is interfering with the individual's function or they have subjective discomfort due to it. Always want to start slow and discontinue after a year. It's often important to reduce reliance on medication in later adolescence because, again, a large number of children will outgrow the tics, or rather, they are transient. A pre medication workup, of course, as always, is needed. So, you want to check the CBC, liver function test, prolactin level, because some of the medications can raise prolactin levels, an EEG as well as an EKG. Physical and neurological exams are important as well. And here's a table showing some of the medications that have had evidence of effectiveness for Tourette syndrome. And these include the alpha adrenergic agonists, as well as some first and second generation antipsychotics. It can be very challenging to treat a child with a tic disorder and comorbid attention deficit hyperactivity disorder. The first line medication to treat ADHD, of course, are the psychostimulants, and those tend to activate and aggravate tics. Clonidine, however, can be helpful in the treatment of ADHD and comorbid tics, as well as atomoxetine. Atypical antipsychotics are occasionally used as well, such as Risperdal or ORAP. And when we have a tic disorder and a comorbid emotional disorder, such as depression or anxiety, SSRIs are typically used. Uh, Again, can adjunctively treat with an antipsychotic as well. Sulpiride is an atypical antipsychotic that is not used in the US at all. But is widely used throughout Asia and other countries. We don't really have a lot of evidence supporting the use of alternative therapies, although there is some anecdotal evidence for the incorporation of physical exercise and recreational activities in general. Uh, no evidence is available to support special diets or vitamin or mineral supplementation or the use of hypnosis.